All right. So thank you guys, and thank you guys for all being here. So considering this is like my master's work, I'm always excited to share this with other people. And the fact that you're here after like 6 p.m. means that you guys must all be a little bit interested too. So I really appreciate you guys all being here. So what we're going to talk about today is childhood pneumonia, which we know is the leading cause of death in children under 5. And we have a lot of questions about this. Like when in the developing world, like in the United States, we don't actually see a lot of mortality due to diseases like this. So we wonder, why do we still see such a high burden of disease, especially in developing countries? And what are we doing right now to reduce this burden of disease? And what are the shortcomings with some of these approaches? And then I'll present some of those things to you, and you guys can come up with some of the solutions to this. Sound good? All right, all excited about it. Okay, so this first graph here shows the different causes of mortality in children under 5. And you can see pneumonia and diarrhea here account for 29% of mortality in children under 5, or about 2 million deaths annually. And so just pneumonia alone accounts for about 1.3 million of these deaths. And this is a graph representing the burden of disease in different regions for pneumonia and diarrhea. And you can see that over 90% of these deaths occur in South Asia and Sub-Saharan Africa. And even within these regions, these diseases disproportionately affect children in the poorest, most rural areas of South Asia and Sub-Saharan Africa. So even within these different countries, there are disparities between perhaps more rural, poorer families and those that have a little bit more income and resources. So we kind of want to understand, what is it about these settings that causes greater incidence and mortality due to these diseases? And for us, it's going to be about pneumonia. So because I'm a little bit of a nerd, I want to teach you guys and maybe see what you guys already know about what pneumonia actually is and how it occurs, right? So right here we have an image of the respiratory tract, and this is basically, when you breathe in through your nose, your nasal cavity, air goes in down your pharynx, your throat, and goes down into your lower respiratory tract, getting into your bronchi, which are the larger airways in your lungs, and then the bronchioles, which are the little airways, and then finally into your alveoli at the end, right? So I think most of us are familiar with this kind of framework for it. And we can divide these into two functional categories of your upper respiratory tract and your lower respiratory tract, which are helpful when we think of different diseases that we might see in these areas. So can someone define pneumonia for me? Anybody? Yeah?
Isn't when you get fluid into your lungs?
Fluid in your lungs, yeah, that's definitely part of what can happen during pneumonia. Does anybody else have anything else they want to add to that? Do you guys know where it occurs in here?
Lower.
Yeah, in the lower respiratory tract. So one of the interesting things about how respiratory diseases work is that it can actually be seen as a continuum of disease that sort of can begin in the nasal cavity, maybe move to the pharynx, and move all the way down into the lungs. And so this is why when you get sick, you can actually think about how it might start off with a little bit of a runny nose, and you might get a sore throat. And if it gets really severe, then you might have some of that chest congestion, and even fluid in the lungs that we would consider pneumonia. And so just to kind of illustrate that, if you have inflammation or infection in your nasal cavity, we consider that rhinitis. If you have a sore throat problem with your pharynx, that's pharyngitis. You can get epiglottitis, laryngitis, which is inflammation of your vocal cords. And then when we move into the lower parts of the lung, the bronchi, you can get bronchitis. And then you can get bronchiolitis when you have an infection or inflammation of the bronchioles. And when it occurs in the alveoli, that's what we call pneumonia. And I always thought that was confusing. I thought a better term for it would have been alveolitis. So I never really understood what pneumonia was for a long time, right? But that's really when that infection spreads all the way down to our alveoli and those air sacs down there. And those air sacs are really where we have gas exchange occurring. So when you breathe air in, you get oxygen going into your lungs, into the alveoli, and you actually have blood vessels all around these alveoli that take in the oxygen. So the oxygen diffuses into the blood, and carbon dioxide actually leaves through there, and that's how you have gas exchange occurring in your body. So what happens during pneumonia, as you said in the back, is that if you have a bacterial or viral infection or something going on down there, your body mounts an immune response. And that immune response is going to lead to a lot of white blood cells accumulating in that area, and can lead to a lot of inflammation, which causes fluid, pus, and different debris to accumulate in that area. And so the problem that we see then is if you have basically a lot of crap in your alveoli, a lot of stuff down there, you can't actually get oxygen in or carbon dioxide out. And so that's really one of the biggest problems with pneumonia, and that's why children die of it, right? So one of the biggest complications that we see leading to mortality can be respiratory failure. And essentially that means when you can't get enough oxygen into your lungs and subsequently into your blood, then you don't have enough oxygen for most bodily functions, and that leads to respiratory failure. Another thing that can happen leading to mortality is sepsis, where these infections that are in your alveoli can actually get into the bloodstream, and once you have, say bacteria or a different pathogen in your blood that can pretty much spread to anywhere, lead to huge inflammation and infection, and can cause mortality through different end organ damage or a few other things that we won't really talk about. So, I think one of the important next things for us to understand is what the underlying diseases actually causing pneumonia are, right? Because later on we're going to start talking about how we actually diagnose and treat pneumonia, but in order to understand how to do that, we should figure out what the causal pathogens are. So in children, one of the most common pathogens is respiratory syncytial virus, or RSV, and that accounts for anywhere from 10 to 40% of severe pneumonia in children. And you'll see that that's a pretty broad range up there. And the reason that's so broad is because viruses can be really hard to identify etiologically. They're really difficult to isolate, so we don't actually know the exact burden of this disease, and it's actually hard to tell exactly how much mortality that accounts for, compared to some of the other figures that you see in this chart. But one of the reasons that these viruses can be so important is that viruses can actually cause mild or less severe pneumonia, but make children more susceptible to these other bacterial infections that can actually lead to mortality. So you can start off with a viral infection that sort of damages the respiratory tract and leave children susceptible to some of these other bacterial etiologies that can really cause severe illness and death. So the most common cause of bacterial pneumonia is Streptococcus pneumoniae, which accounts for almost 33% of mortality in children under 5. And the second leading bacterial cause is Haemophilus influenza, which causes almost 16% of mortality in children due to pneumonia. And then the last one we have on this list is the influenza virus, which accounts for about 11%. One of the important things to note about this is that these two viral etiologies are actually both vaccine preventable. We have vaccines that exist and that are pretty decent at preventing these two illnesses. But one of the biggest issues is that these just aren't available and aren't used in a lot of developing countries. So one of the points that I was alluding to earlier that I think will be helpful in kind of understanding our discussion of how we diagnose and treat pneumonia is the difference between these bacterial and viral pneumonias. So as we said earlier, viral pneumonias can be pretty common in children, accounting for almost 50% of the pneumonias in children. But you think about how we might, so I guess I'll tell you now, normally pneumonia is treated with antibiotics, right? That is the standard of care in developing countries. But when you have a viral pneumonia, those treatments, antibiotics don't actually work on viral etiologies, right? So for up to 50% of pneumonias that we see in children, the treatment that we give them isn't actually going to be effective. And the thing with viral pneumonias is that they are often a little bit less severe, so they don't lead to as many cases of mortality as the bacterial etiologies, and that's kind of one way we can distinguish them. So we know that if a child presents with chills, fever, and really severe respiratory distress, chances are that they have a bacterial etiology of infection. But some of the other findings that we see here, like for example, focal auscultatory findings versus diffuse bilateral auscultatory findings, that's like kind of stuff that we hear when a physician examines a child with a stethoscope, right? Focal meaning we see pneumonia findings in just one area versus diffuse bilateral auscultatory findings meaning we see it in a lot of different regions. And so those are kind of things that might be harder in a developing country setting or a low resource setting in order to diagnose. So that's another one of just kind of the highlighting, another way to kind of highlight the difficulties and differences in developing country settings versus maybe in the US where we might be able to more specifically isolate and understand the causal etiology of pneumonia. And that's why we're able to deal with it and treat it a little bit better in places like the United States. So we're going to talk briefly about risk factors. And so this is essentially how do we get from having these pathogens all around us to actually getting kids sick? What puts them at greater risk for actually getting these diseases? And what's the difference between, say a place where like the United States where we have a lot lower incidence of pneumonia, but much, much lower rates of mortality due to pneumonia. So we're going to be discussing why do children actually get these diseases and why does it lead to pneumonia, right? So there are a few environmental factors that we're going to talk about. And the first on this list is hygiene and sanitation. I think this is an interesting fact. The #1 most cost-effective intervention to reduce the incidence of diarrhea and pneumonia in children is actually hand washing with soap and water. And that just doesn't happen in a lot of settings, right? Especially when you're looking at, like really, really poor areas, maybe even like slums, where we see crowding being a huge problem. The ability of disease to kind of spread and exist in a lot of areas is really huge. And so because we don't have some of those basic mechanisms of preventing disease from occurring, we see a lot of incidents in these settings. And another interesting thing is that I've actually, as Parsa kind of told you guys, that I've done a little bit of work with is indoor air pollution. So do you guys know how most people cook their food or get heating in developing countries? Yeah, stoves, just like the one right there, right? So most people, about half of the world's population, actually fulfills all of their cooking and heating needs through open fires. And the problem with these open fires is a lot of times when you're burning stuff inside of a home, that releases a lot of particulate matter. And this is really important for children because think of who's in the home while cooking is happening. It turns out that women spend anywhere from 3 to 6 hours cooking in the kitchen in these developing country settings. And if there's a child under 5, where do you think that child is? Really young children spend a ton of time on their mother's backs, and often other children older than that will just be in the house and in that setting. And by being exposed to all this carbon monoxide or carbon dioxide, this fine particulate matter, that can lead to a lot of damage to the respiratory tract, make them susceptible to a lot of respiratory infections. So some studies have shown up to 80% increase in the incidence of pneumonia in children who are exposed to air pollution like this. And so the second category of risk factors that we should talk about is the biological risk factors. The first on this list is a lack of breastfeeding. And it turns out that the risk of pneumonia in children who haven't been breastfed compared to the risk of pneumonia in children who are exclusively breastfed for the first 6 months of life is 15-fold. So those children who haven't been breastfed are 15 times more likely to get pneumonia and possibly die from it than those who have been breastfed, which is a huge difference. So that's another intervention that's pretty much free for people to do, right? To use breastfeeding to feed their children, but doesn't happen enough in these settings. And one of the things I've actually heard is that, especially in countries like this, when a child is actually born in a hospital, right away they'll be given a free can or bottle of formula. And that happens because these formula companies they want people to think that formula is like kind of the Western standard of feeding. And so they kind of push that upon children when, by not breastfeeding, children don't get some of the antibodies, some of the immunoglobulins that they need from breast milk from the mother in those initial years of life to really help them before they develop their own immune systems. So that's another thing that puts children at a huge risk for these kinds of infections. And another thing related to that is actually the most deaths we see due to pneumonia, about 80%, actually occur during the first 2 years of life. So that kind of passive immunization that we get from breastfeeding is really essential during those 2 years to get children to be able to actually fight off infections due to things like pneumonia. And so a couple other things that we see in these children are undernutrition and immunocompromised children. Immunocompromise can occur from having other infections. A lot of the time HIV can lead to a lot of susceptibility in children where we see high prevalence of that disease. And undernutrition in general makes children have weaker immune systems and be less able to fight off these kinds of infections. So those are all things that are pretty prevalent in these low resource settings and lead to increased incidence and mortality due to pneumonia. All right, so time to put on our doctor hats. So if a child is going to come in and present with pneumonia, what kinds of signs or symptoms do you think that child might show? What would indicate to you as a healthcare provider that a child might have pneumonia?
Has a cold,
A cold, yeah, so how would you define a cold?
fever, coughing,
Yeah.
and also very weak,
Yeah,
not energetic.
great. Fever, coughing, weakness, anything else? Anyone? All right, well, I won't push you too far, and those were actually really great. Those were the first two on my list: fever, coughing, also difficulty breathing, right? And we talked about how this can occur. If a child has a lot of congestion going on in their lungs, they're going to have a harder time getting oxygen down there. And then another sign that we see is lower chest wall indrawing. And basically, lower chest wall indrawing is when you think, everybody take a deep breath in right now. what does your chest do? It expands, right? And so the problem that we see in children who have pneumonia is that their lower chest wall will actually go in when they try to breathe in because they're working so hard to try to pull oxygen in. Normally, what's responsible for bringing air into your lungs is that your diaphragm moves down. It expands the space in your thoracic cavity, allows your lungs to expand. But if you have a lot of fluid, a lot of pus built up in your lungs, you can't actually bring oxygen in, so you'll start using other muscles to try to bring air into your lungs, and that's why we see lower chest wall indrawing in children. And I'll show a video in a minute to kind of illustrate how that occurs. So, to diagnose pneumonia currently in low-resource settings, we actually use difficulty breathing and lower chest wall indrawing as our diagnostic criteria. And actually, difficulty breathing or a high respiratory rate is the main diagnostic criteria used by the World Health Organization in the diagnosis of pneumonia for children. And this chart basically shows how we go about categorizing different respiratory rates. And so a respiratory rate is basically the number of breaths a child takes in a minute. And what we see based on this chart is if a child is breathing 60 breaths per minute or above, that a child 0 to 2 months, then you consider they're breathing too fast, and that would be diagnostic of pneumonia. If a child 2 to 11 months is breathing 50 breaths per minute or above, that would also be diagnostic of pneumonia. Or if a child 1 to 5 years of age is breathing 40 breaths per minute or above, that would also be diagnostic of pneumonia in a low-resource setting. These are the criteria put out by the World Health Organization that are used in most low-resource settings that adhere to these guidelines. And if any of these children has a respiratory rate of 70 or above, that's the diagnostic criteria for severe or very severe pneumonia. And that would actually indicate to the provider that they should be referred to a hospital for further follow-up care. So these are pretty simple criteria, and it turns out that they're actually pretty good at detecting cases of pneumonia. This detects about 85% of cases of pneumonia and more than 80% of the severe cases that could be potentially fatal. One of the biggest issues with this is that it actually leads, so if we diagnose a child with pneumonia based on this criteria, the standard of care is to give them antibiotics. The problem with this method is that it leads to the provision of antibiotics for 70 to 80% or 70 to 80% of children not actually needing them who receive them from this criteria. And the other thing that we talked about is lower chest wall indrawing. So I'm just going to play this video to illustrate what that looks like. Oh, it is not working. Sorry guys. Well, anyway. Yeah, question?
So I have a question about the 70-80% of children who do not need antibiotics. Is it because they have pneumonia but it does not need to be treated with antibiotics, or is actually some other reason to cause them to have elevated breathing rate and they actually do not have pneumonia?
I think the majority of the time it is pneumonia related, but recall that a lot of times it could be of a viral etiology, or sometimes the body is capable of basically curing or basically getting rid of the infection on its own, so antibiotics aren't necessarily required for that. And so, it is probably the best we can do kind of right now because we want to make sure that the children who do need it are getting antibiotics, right? So I guess maybe later we'll talk a little bit about how we can potentially improve upon that.
Or it could be wrong.
Yeah, that's also possible. Okay, so continuing with this. So remember just what lower chest wall indrawing is we talked about it earlier. It's sort of that retraction and bringing in of the chest when a child is working especially hard to get oxygen into their lungs. And so lower chest wall indrawing is actually predictive of lower respiratory infections in 60 to 80% of cases. So you will actually have a respiratory illness in 60 to 80% of the cases where we have lower chest wall indrawing, and it's used as an indicator of severe disease according to the WHO guidelines. One other thing that is used in terms of diagnosis of pneumonia is whether a child has hypoxemia or not, right? And so hypoxemia is actually having low blood levels of oxygen. And so this is related to what we talked about earlier. If a child isn't able to get enough oxygen into their lungs, they're not going to be able to get enough oxygen into their blood as a result. And so this device that we see right here is called a pulse oximeter, and it's actually used to measure the oxygen saturation of the blood. So these can actually be really helpful to tell if, going from having difficulty breathing, if we're actually having issues with oxygenation of the blood, which are what lead to respiratory failure and can lead to death like we talked about earlier, right? And it turns out that these devices are pretty good at diagnosing hypoxemia, but they're often unavailable in these low resource settings. And the next sort of standard of care would be to deliver supplemental oxygen if we find out that a child doesn't have high enough oxygen in their blood, right? But supplemental oxygen is something that's pretty hard to come by in most rural health clinics. Even a lot of higher level care facilities in rural settings don't actually have oxygen tanks available for things like this. So that's another difficulty that we run into. So the next thing I want to do is actually compare how these diagnostic standards relate to the diagnostic standards that we might use in the United States. So it turns out that for mild or uncomplicated lower respiratory infections, diagnosis in the US is actually made based on clinical signs as well. You don't always have further follow-up. And one of the things that your doctor will usually do if you go into the hospital complaining of some kind of respiratory illness is that they'll put on their stethoscope, they'll listen to your lungs, and that can actually tell us a lot about kind of what's going on. Usually if there's pneumonia, you won't hear breath sounds like you normally would in the lungs, and that will indicate that there's some sort of inflammation or infection in that area. And often chest x-rays will also be taken, and I think that kind of has more to do with the standard of care in the US, where we want to make sure that we're not missing any potential disease that could be occurring, even though it's not completely necessary unless cases are a little bit more severe. But if a chest x-ray is taken, as you can see in this image, you'll see like it's that whiter space that those red arrows are pointing to, which basically shows that there's a lot denser material in that area, and that's due to the accumulation of fluid or debris or something else where it should normally be clear and filled with air in the lungs. So those are other kind of standards of care that might occur in the US. It turns out even in the US, we don't actually look for the etiology of pneumonia. We don't actually look for which specific microorganism is causing the disease. And can you guys think of different ways that we might actually look for that microorganism? How could we figure that out in a case of pneumonia? Like, what would you do if you were a doctor?
You could do a culture.
A culture, right. So what kind of culture? Like, what material do you think you might sample?
If you could somehow get the actual fluid, I don't know if that's practical at all. But
Yeah, that is one potential mechanism. Is there anything else that you guys can think of?
blood test.
Blood test, right? Yeah, you could also do a blood culture, and you could even look at the number of white blood cells in the blood. That could actually be pretty helpful for indicating whether it's a bacterial infection versus a viral infection or something else. Kind of going back to the idea of different kinds of culture. It turns out, so you could try to culture the sputum that somebody coughs up. One of the issues with children is that children often don't produce a lot of sputum. They actually, usually just swallow kind of whatever is in that area. Another thing that you could do is, use a throat swab. I'm sure a lot of you have actually gotten throat swabs in a clinic here before. But it turns out that we have a lot of bacteria in our bodies, and throat swabs don't necessarily tell us what the etiology of disease for something like this is. And the other thing that you said is, you could go all the way into the lungs, like do a biopsy or draw out some fluid or something like that and try to isolate the organism. But that's a pretty invasive procedure, and that's really not done often, even in the United States. So kind of what we're seeing as a result of this is that we don't often really find out what the causal organism is, and sometimes our standard of diagnosis is the same clinical standard that is used in other settings, right? So based on this, the standards of treatment for pneumonia in developing countries, and these are the standards used by the WHO, directed in their guidelines, are first oral antibiotics, either amoxicillin or co-tremoxazole twice a day for 3 days. In cases of severe disease, injectable antibiotics can be given. And either of these treatments has been shown to produce a 25% reduction in all-cause neonatal mortality and a 42% reduction in pneumonia-specific mortality in neonates. And I use neonates here specifically because that time period is where a lot of the mortality in children actually occurs. And also oxygen supplementation has been shown to reduce mortality in severe pneumonia by about 35%. And overall, getting the appropriate case management for pneumonia can reduce case fatality by 29 to 45%. So this last chart right here is actually a summary of what's provided in the WHO guidelines for the management of pneumonia in children. And so you can basically see that starting over here, one of the first things to do would be to count the breathing rate in a child, look for that chest indrawing that we talked about, and Stridor and wheezing are listed right here. Those are actually things that you would hear on a stethoscope. It's kind of due to turbulence of airflow in the lungs, and you could hear if there's some sort of inflammation or something going on in there. And basically what we can see right here is that if there are none of those signs, the classification would just be a cough or a cold. You might give the child some kind of inhaler or bronchodilator, maybe a cough syrup or something, but you wouldn't get the antibiotics that we talked about. If the child does have fast breathing, meeting the criteria that we talked about earlier, they would be diagnosed with pneumonia, given antibiotics, told to come back to follow up in a couple days. And finally, if we see chest indrawing, stridor, which is again one of the auscultatory findings that we talked about, or a severe sign, a danger sign is what they're called, of maybe unconsciousness in the child, not being able to drink or eat anything. Those are considered really severe signs of disease, and that's when they might get an injectable antibiotic and be referred to a hospital or a higher level of care facility. And so these are the basic standards that are used to diagnose and treat pneumonia in most low resource settings as directed by the WHO. So what's the problem? Why do we still see pneumonia causing so many deaths? Based on seeing the similarities between diagnostic criteria in the US compared to developing countries, why are so many children still dying of pneumonia? And why does it disproportionately affect these developing countries? So this chart right here shows some of the interventions that we have right now to improve health in children. Remember we talked about breastfeeding at the beginning, about how exclusive breastfeeding can reduce the risk of mortality related to pneumonia. It turns out that only 39% of children are exclusively breastfed during the first 6 months of life. And there are a few other supplementations and immunizations here that are relevant to different diseases, but one of the ones that we talked about was HIV, or Haemophilus influenza type B. And we see that there's only 43% of children actually receiving that HIV immunization, leaving them at risk for that which causes almost 16% of mortality due to pneumonia. And then finally, the ones that we're most interested in terms of diagnosis and treatment are care seeking and the provision of antibiotics. And it turns out that only 60% of children with pneumonia are actually sought care for, and only 31% of them get antibiotic treatment. So they're not receiving the standards of care that are given, which could account for why mortality rates are so high.
Quick question.
Yeah?
What's the coverage of the strep pneumo vaccine for children?
I'm not actually sure about that. I think it is low, yeah. We're actually going to figure. And so we kind of have a competing problem here in that, one, we don't have enough antibiotics being given to children who need them. But also based on that diagnostic criteria, the children who are diagnosed with pneumonia, a lot of them don't even need antibiotics. So we have a lot of children getting antibiotics that don't need them. And it's led to this problem of resistance developing. And we have that in the US, we have this in other countries as well. And this is kind of globally an issue that we're facing. One of the things kind of unique to developing countries that we see is when children are given antibiotics, often people don't take their full course of antibiotics. And that's something that I'm not sure how you guys feel about this, but I feel has been hammered into me over and over when we talk about taking your full course of antibiotics. One of the biggest issues in these countries is that, considering the cost of antibiotics and the availability, if somebody is told to take some antibiotics, they might take it until they feel better, give to the child until the child seems better, and then stop without taking the full course, especially because of the high cost. And this is kind of something that I was told about when I went to India, and I'll tell you guys a little bit more about some of those experiences later. But the way that leads to resistance is if a full course of antibiotics isn't taken, essentially you might kill off a lot of the bacteria that are susceptible to the antibiotic, but the ones that are left over that maybe haven't been cleared yet, if that course is stopped too early, might be some of the ones that are strongest, some of the ones that are most resistant to that bacteria. And if your body isn't able to clear that infection, those are the ones that can proliferate and spread, and later the same antibiotic might not be effective against that. And in fact, we see about, or even greater than 50% resistance to the cotrimoxazole treatment in some settings. And so that's actually why amoxicillin is I think, used as the first line right now in pneumonia treatment, as directed by the WHO. So just kind of to recap a lot of the issues we've seen so far. In terms of incidence, a lot of children aren't getting the immunizations they need, and there are a huge number of risk factors in these settings for actually contracting the disease. In terms of diagnosis, we have diagnostic mechanisms, and they're possibly sensitive enough, but they aren't very specific. So we have a lot of children being treated who might not need the treatment. And we also have health workers who aren't necessarily trained well enough to diagnose pneumonia. Even though I think the criteria might seem straightforward enough to us, these aren't actually implemented really well in low resource settings. And that's something that we can talk about a little bit more later on. And then in terms of treatment, here are a lot of things that we've talked about already in terms of not seeking enough care for children who need it, not getting antibiotics to those who need it, maybe even not having the antibiotics on hand, or even supplemental oxygen. Really, when we're concerned about pneumonia mortality, we're concerned about the most severe cases, the children who might need that supplemental oxygen, and that's something that's pretty hard to find from what I've seen when you are in a rural setting. So the last thing I'm going to talk about is a little bit of the work that I've done. And so I've actually been working on evaluating the quality of care for childhood diseases with an organization called World Health Partners, which has set up a social franchise and telemedicine network in Bihar. And this is actually what I'm doing for my thesis. So I'll tell you guys a little bit about this, and it's kind of a case study for how treatment, what treatment is like right now for pneumonia and diarrhea actually, and how we can potentially improve upon these things. So in the setting of India specifically, medical care is supposed to be provided by the government for people in the lowest socioeconomic divisions of the population, right? But there are a lot of problems with this public sector provision of healthcare. One is that the quality of healthcare is pretty poor, especially in rural settings. People can't get to cities, can't actually get to these health centers. They lose, an entire day or two of wages if they have to make their way out there. And even when they get there, they have to wait a really long time. Sometimes can't even see a doctor who's there. And as a result, 2/3 of households across India actually get healthcare from the private medical sector. And what we mean by the private medical sector is informal providers. So basically anybody who sets up, a little medicine shop. Often these might be called quack doctors, or any like traditional healers or providers like that. And those are where people get most of their care in India. And the problem that we see with this is that these providers don't really have any formal qualifications. There's no real training or regulation for these providers, and so we don't really know anything about the quality of care that they get. So while we might have these nice WHO guidelines for the diagnosis and treatment of pneumonia, there's no real guarantee that anybody has been educated on those, especially where people get the majority of their care in these settings. So one example I looked at specifically was in the state of Bihar in India. And Bihar is one of the poorest states in India, and has some of the lowest rates of education, and its under 5 mortality rate is about 84.8 per thousand. And just as a reference, in the US, our under 5 mortality rate is about 7 per thousand. So that is a lot higher, it's pretty significant. And in Bihar, 93% of households report not using government health facilities at all. So when I was in India, what I did was work with an organization called World Health Partners that was focused on finding ways to improve the quality of care for children with diarrhea and pneumonia. And their idea was, okay, if most people are getting their care from this private medical sector, why don't we work to improve the quality of care provided through those clinics based on what we know? So just to give you guys an idea about how it works, they've taken this informal medical sector, they got a little bit of funding, and set up some infrastructure. And what they did was they actually worked to train providers on the guidelines that I showed you. And they actually set up a drug supply network to make sure that they had adequate access to antibiotics and other things that might be needed to treat children. And one of their big things that they've done is set up this telemedicine network where doctors in the village can actually call in, or those who have the infrastructure for it can actually use a computer to web conference with a doctor in the city to make sure that children are getting the right kinds of diagnosis and treatment. And the idea with this is to increase what providers know about these diseases and to increase their adherence to these guidelines that we see. So again, I just kind of want to reiterate the fact that even though we have a decent diagnostic structure that does capture, as we said, 80 to 85% of cases, it isn't necessarily implemented in a lot of areas, and that means that could be one of the reasons that we see a lot of mortality still occurring. And so the effect of this overall is to, in hopes of increasing the quality of care that we see, increasing care seeking, decreasing the unnecessary prescription of antibiotics while increasing provision rates for those who do need it. And overall goals of this are hopefully to reduce childhood mortality and reduce antibiotic resistance. So without getting into this, the last slide I actually have for you guys is just some of the things that I learned from being out there. And one of the kind of really interesting lessons that I saw is that these healthcare providers that most people go to for care, especially children, they're not just healthcare providers doing a public service. They're actually like, this is their business, this is their livelihood. And one of the interesting ways that that contributes to how illness is treated is that often patients will come in with the idea that antibiotic treatments are the Western standard of medicine. And so they'll come in wanting something specific. And even if we have this framework for how things should be best treated and dealt with, even if the child doesn't need antibiotics, even if they don't have pneumonia according to the guidelines that we have, they might actually want that standard of care. And essentially it's in the businessman's best interest to give that person antibiotics because it makes their client happy. They also get higher payments for the provision of those medications. So I think that's just like one idea, like one of the problems we see with even knowing what the best standard of care might be. Those kind of standards aren't necessarily implemented in these settings. So I think that those are all issues that we need to consider when we frame our approach for how to deal with these high rates of mortality and how to deal with some of the shortcomings that we've seen when dealing with this. So that's all I have for you guys. Thank you guys for sitting through that with me. Does anybody have any questions or any ideas that they have for ways that we can improve how pneumonia is diagnosed, treated?
So you mentioned that this case study is your thesis. I'm not really familiar with your program. So you're in the process of writing this thesis, and do you have plans to get back to NEPAR? Or what's the next step for you, I guess?
Yeah, so I was in India last summer actually when we actually did the data collection for this plan and sat in these rural clinics and looked at how the providers interacted with children who came into the clinics and saw what they were doing and also did some interviews. And I guess like another tidbit of information from that is a lot of the times when a child is taken to a provider, they might only spend 3 minutes with the child, which is like a really short period of time. So another little fact from the field that I want to throw at you guys. But yeah, so now I have some of the data from it and I'm working on doing some of the data analysis and writing the thesis.
So I guess it's sort of a vague question, sort of numbers-wise, what's the sort of comparison between these sort of private health practices versus sort of the government implemented hospitals and clinics and things like that? Like maybe how many doctors are sort of working for the government versus how many of these sort of private practitioners are there? Is there some sort of numbers there that?
I actually don't know the distribution of like the number of providers that actually exist in each of those settings. I'm not sure. That's a good question though. Yeah.
Did you see a lot of counterfeit medicines when you were there?
So I actually would have no way to tell if they were counterfeit or not. And so one of the things that the organization I was working with was actually doing was they were distributing their own branded supply of medications. So that way, like they're trying to create basically this well-known brand that represents some sort of standard quality of care. But I actually don't know about how good a lot of the other medications that are being given are.
I have a question about the quality of medicine between the public and private sector. Within the private sector, there's a lot of variation, but what about the government sector? Is it more, what is the quality of that?
I think the same variation still exists. There have been like some baseline studies that we've seen, and it really isn't that within this public sector they provide the highest quality of care. It's still not too great. And actually, so Dr. Julia Walsh right here is my advisor, so she might have some more information on this if you have anything you want to share.
In the government facilities, we're talking about counterfeit medicines, right? And the quality of care.
Quality of care. I would think there would be more regulation in the government sector.
Yeah, the problem in the government sector is, well, there are lots of problems. So one, many of the doctors aren't there. Their salaries are usually low. And so what they do is they move on to private practice, and so they spend this disposable amount of time in public clinics. The public clinics will have regular, will have high-quality medicines prescribed through that, the local system, public system. But it's just not many public clinics that are available in Bihar and Uttar Pradesh, which is where these World Health Partners, a huge NGO, works. Cover about 30 million people.
Another kind of interesting story I heard when I was out there was that often doctors who are supposed to work in these public clinics might actually just take most of the salary they get from it and give the person who actually evaluates them a cut of it to say that they were there but never actually show up. So there's a lot of problems with corruption in those settings too.
You talked about strep pneumo and Haemophilus influenza.
Mm-hmm.
In the developed world, we talk about mycoplasma pneumonia and chlamydia pneumonia, and maybe Legionella. Are those not an issue in children in developing countries, or not as much an issue, or unknown, or what?
I think that they still definitely exist, but the burden of these diseases is so high, especially because the prevalence of these infections, like kind of in the population, is so high that we see a lot of them spreading. In a setting like the US, like we have a lower burden of disease to start with, so the spread of those same diseases is much lower. And I think that this is why, like empirically, we do look at these cases.
In that 3 minutes that you observed physicians, were they using things like temperature, breath rate? Were they using those diagnostic criteria?
So I didn't see anybody take a temperature. I did mostly just see people observing and kind of talking a little bit, but it was a little bit, I feel a little bit disheartened almost like telling you guys about this too, like there's just not a whole lot that's done during those visits. It's pretty much, in and out, and there's like, I think they tried to prescribe a medication as a solution, but there's not a lot of diagnosis.
So you showed the chart where there was a general guideline on the breath count. I was wondering about like the borderline cases, because it seemed pretty black and white, like below 40 or 40 above. But if something's like 41 or 39, like what do they deal with? How do they deal with borderline cases?
So I'm not actually sure what individual providers would do, but I think that also is kind of might be related to the point about how a lot of these health workers are pretty unskilled, right? So my first answer, I think if somebody were trained in this criteria, I feel like they might actually follow it exactly, right? So if it was 40 or above, I imagine that if they were following the criteria, they would actually treat a child. And so it's hard to get people to use more clinical judgment when there's not a lot of like other skills or expertise. Does that make sense?
Yeah. I mean, do you think this is a potential, is it a big problem, or is it something that's like built in? It's an error that gets set.
Yeah, I think it's definitely a problem. Like that contributes to why so many children who get antibiotics under this criteria might not actually need them, right? So I think that if there were, I don't know, if you have ideas about how we can better address it, that would be great. Something to think about. Yeah.
So I've heard about like smartphone kind of mediated diagnosis and remote doctors. Is that something that's being put in place here? Is that so hard to provide with the technological kind of stuff?
Yeah. So the system that this that World Health Partners actually uses is that it has cell phone consultations where using a standard cell phone, people can actually call in and talk to doctors in their network in the city. Or for providers who actually have a little bit more in terms of resources, they actually allow them to purchase a computer and set them up with this teleconferencing software. And it's actually really cool because it has attachments like for like a basic EKG and actually like for the basically a stethoscope head so you can hear what lung sounds can sound like. So those things do exist and are being used in some areas. And I think one of World Health Partners' big objectives is to see if it actually helps or not.
you've been looking at, is pneumonia like the main type of respiratory illness that's seen in children, or are there other illnesses that kind of present the same symptoms that might cause difficulty providing differential diagnosis based on those the things that you've shown us today?
Yeah, as far as I know, it's mostly pneumonia. Other respiratory infections might not necessarily be as severe, like kind of, and I haven't really seen a lot on this. Like I'm sure things like asthma and things like that exist based on how much children are exposed, but things that really lead to mortality, I think, are pneumonia.
Is there any overlap in like areas where TB is really prevalent?
Oh.
For example?
Yeah, TB is, yeah, you're right. That's definitely another cause. I actually don't know where TB was on that chart. TB is definitely an issue that's still pretty prevalent, and that's actually one of the other problems that they're trying to address, and it could be similar.
Is it possible to make a pulse oximeter that's solar powered?
I don't know. Does anybody have any ideas on that?
Much electricity?
Yeah, that is actually like one of the really big concerns is like not having electricity in these areas, right? So something like that would sounds really useful.
In the ideal case for a diagnosis, once you diagnose a child as having pneumonia, that doesn't necessarily mean needs antibiotic as a treatment. So in the ideal case, let's say in a developed country like the United States, how is that determination made to, okay, we need to treat this case with antibiotics versus we do not?
Yeah, so I think in the United States, there is, doctors definitely do, I think, a lot more in terms of their clinical diagnosis, and based on some of the related signs, maybe like related to the onset, whether it was really more sudden, kind of indicates bacterial versus, if it's like a slower progression from, like having some rhinitis and pharyngitis, and less difficulty breathing, then it might not necessarily be treated with antibiotics. And I think that something that occurs pretty often in the US is getting a chest x-ray if there is like a question about that. Yeah.
Sorry, can I ask a question? So you mentioned that a lot of the sort of the attitude of practitioners sort of affects sort of the care that the patient is receiving. So in your opinion, do you feel like sort of the challenge right now is sort of technology limiting, or do you feel like there may be the need sort of for a sort of more fundamental attitude change in how care is provided? Because if it makes somebody more money just to provide antibiotics, but providing technology, so they'll actually end up providing less antibiotics. Maybe they will not be as motivated to actually use that technology, even though it might be better for the patients.
Yeah, I'm inclined to say the latter for right now in terms of it's more about perhaps like education and this cultural shift in terms of how we actually deal with and treat patients in these settings. Just because the biggest problems that we see are the fact that children don't actually, care isn't actually sought for a lot of these children, and even if care is sought, antibiotics might not necessarily be given, right? And so I think that addressing those issues doesn't necessarily have to do as much with the diagnosis of pneumonia, but kind of recognizing, I guess a little bit of diagnosis in terms of care seeking, but do you know what I mean? Like, I don't necessarily think that a better diagnostic approach would solve those problems.
People who have pneumonia smell differently and detect the way they do with someone, I think they're working on with tuberculosis. Animals might be able to smell.
There's nothing like that I'm aware of with most types of pneumonia. There are certain pneumonias, like aspiration pneumonia, that are often caused by gram-negative bacteria, and those smell really badly. But those are much rarer, and not necessarily the same type of community-acquired pneumonias that we're talking about here. But yeah, that's not something I've heard anything about, so it would be really interesting if there's any other research on that. Yeah.
Just before you were talking about the antibiotic resistance, I was wondering if you know what the prevalence of that was.
Of resistance?
Yeah.
So I've seen that to the cotrimoxazole, it can be greater than 50% in some places. And it's actually kind of interesting with pneumonia, unlike some other things, even if there is some resistance, you can use a higher dose of the same antibiotic to still treat it. And so that's kind of one of the things that they've been doing to deal with that, and also switching to amoxicillin now for more cases. But I think it's something that's continuing to develop. And I think that we're kind of going down the line of our antibiotics with a lot of things, right? And so even though like we have options right now, that won't necessarily be the same in the future. And I forget like with certain, is it with gonorrhea that we're on one of our last lines of antibiotics pretty much now, right? So I think that's kind of like the worst case scenario we see for this kind of resistance developing in different illnesses.
Thanks.
All right.